Pancreatic cancer has a reputation for being silent, for being discovered too late, for being the kind of diagnosis that arrives without warning, and for many years, that reputation was largely accurate. But what is becoming clearer through more recent research and clinical experience is that the body very often does give signals well before a diagnosis, signals that are easy to dismiss individually because they overlap so much with ordinary aging, digestive sensitivity, or simple fatigue. The problem has never really been a complete absence of symptoms. The problem has been that these symptoms rarely arrive as a single, obvious red flag. They arrive scattered, subtle, and easy to explain away one at a time, which is exactly why this particular cancer has earned its reputation for being caught late, not because the body stays silent, but because each individual signal sounds quiet enough on its own to be reasonably ignored. Today, I want to walk through 8 specific symptoms that deserve real attention, particularly when several of them appear together or persist longer than would be expected from an ordinary, temporary cause. I want to be very clear from the start that having one of these symptoms does not mean you have pancreatic cancer. The vast majority of people who experience any single symptom on this list have something far more common and far less serious. But knowing this list, and knowing specifically when a symptom crosses from ordinary into something worth a focused medical evaluation, is information that genuinely matters, because earlier detection meaningfully changes outcomes with this particular cancer more than with almost any other. Stay through to the 6th symptom, because it is the one that gets attributed to so many other causes that it is almost never connected to the pancreas until much later than it should be. Before going through the list, I think it helps to understand a little about why the pancreas in particular tends to produce such subtle, easy-to-miss symptoms compared to cancers in more visible or more frequently examined parts of the body. The pancreas sits deep in the abdomen, tucked behind the stomach, surrounded by other organs, which means it cannot be felt during a routine physical exam, the way a lump might be felt in breast tissue, or a skin change might be noticed on the surface of the body. It also does not have nerve endings that produce sharp, localized pain in its early stages the way some other organs do, which means early tumor growth often produces vague, diffuse discomfort rather than a specific, easily pinpointed pain that would prompt urgent investigation. Additionally, the pancreas performs 2 very different jobs simultaneously, producing digestive enzymes that break down food and producing hormones like insulin that regulate blood sugar, which means a problem within the pancreas can manifest through digestive symptoms, blood sugar changes, or sometimes both together, depending on which part of the organ and which function is being affected by tumor growth. Understanding this dual function actually helps make sense of several symptoms on today's list that might otherwise seem like an unusual combination to associate with a single organ. The first symptom, and one of the more recognized ones once people understand the connection, is unexplained. Gradual weight loss, meaning weight loss that occurs without any deliberate change in diet or activity level, often accumulating to a meaningful amount, sometimes 10 pounds or more, over a period of just a few months. This happens through several overlapping mechanisms. A tumor in the pancreas can interfere with the gland's ability to produce digestive enzymes properly, meaning food, particularly fat, is not broken down and absorbed as efficiently as it should be, so calories that are eaten simply pass through the digestive system without being fully utilized. Additionally, cancer of any kind can increase the body's overall metabolic rate through complex biological processes related to how tumors interact with the body's inflammatory and hormonal systems, meaning the body is burning more energy than usual even without any change in activity. The reason this gets dismissed so often is that gradual weight loss can have dozens of completely benign explanations in older adults, ranging from simply eating less due to reduced appetite that sometimes accompanies aging, to medication side effects, to other manageable digestive conditions. What distinguishes weight loss worth specifically investigating is the combination of being unintentional, being progressive rather than a one-time drop, and ideally occurring alongside one or more of the other symptoms on this list, rather than appearing in complete isolation with no other accompanying changes. The second symptom is a particular type of abdominal or back pain that has a somewhat distinctive character once you know what to look for. This pain typically locates in the upper abdomen, sometimes described as just below the breastbone, and frequently radiates straight through to the middle of the back, which is a pattern that happens because of the pancreas's deep central location pressing against nerve pathways that run along the spine. Patients often describe this pain as a dull ache rather than a sharp stabbing sensation. And a detail that comes up repeatedly is that the pain tends to worsen after eating, particularly after meals containing significant fat, and sometimes improves somewhat when leaning forward or curling into a position that reduces pressure on the area. This pain pattern gets misattributed constantly to far more common causes, including ordinary back strain, arthritis of the spine, or general digestive discomfort, all of which are statistically far more likely explanations for back pain in an older adult than pancreatic involvement. What makes this particular pain pattern worth paying closer attention to is the specific combination of upper abdominal location, radiation straight through to the back, and a clear relationship to eating, particularly fatty meals, rather than a relationship to physical activity or position changes that would be more typical of musculoskeletal back pain. The third symptom, and one of the more medically significant ones on this list because it often points toward a very specific underlying mechanism, is jaundice, meaning a yellowing of the skin and the whites of the eyes, sometimes accompanied by dark urine and pale clay-colored stools. This occurs when a tumor, particularly one located in the head of the pancreas, which sits closest to the bile duct, physically obstructs the normal flow of bile from the liver into the digestive system. When bile cannot flow properly, a pigment called bilirubin accumulates in the bloodstream, producing the yellowish discoloration that is visible in the skin and eyes, while the absence of bile reaching the intestines causes stool to lose its normal brown coloration and become notably pale. This particular symptom, when it appears, tends to prompt medical evaluation relatively quickly, since jaundice is visually obvious and rarely ignored once someone or a family member notices it, which is actually one of the reasons pancreatic cancers located in the head of the pancreas are sometimes caught somewhat earlier than tumors located in the body or tail of the organ, which do not cause this same bile duct obstruction and therefore do not produce this visible warning sign until much later in the disease process, if at all. The fourth symptom is a new onset of diabetes or a sudden, unexplained worsening of blood sugar control in someone who already has diabetes that has otherwise been stable for years. This connection surprises many people because diabetes is overwhelmingly associated with weight, diet, and genetics, rather than with cancer. But the relationship with pancreatic cancer specifically is well documented and biologically logical once you understand that the pancreas is the organ responsible for producing insulin in the first place. A tumor growing within or near the insulin-producing cells of the pancreas can directly interfere with normal insulin production and release, and tumors can also release certain substances into the bloodstream that independently worsen insulin resistance throughout the body, through mechanisms that researchers are still working to fully understand. What makes this particular symptom worth paying close attention to is the timing and the lack of an obvious alternative explanation. Diabetes that develops in someone over 50, particularly someone who does not have the typical risk factors like significant excess weight or a strong family history of diabetes, or blood sugar that suddenly becomes difficult to control, despite years of stability on the same medication regimen and without any change in diet, weight, or activity level, represents a pattern that deserves specific consideration of pancreatic involvement, even though the overwhelming majority of new diabetes diagnoses in this age group have nothing to do with the pancreas in this particular way. The fifth symptom is digestive disturbance that goes beyond ordinary, occasional indigestion, specifically a pattern of persistent nausea, a feeling of fullness after eating only small amounts of food, and stool that becomes oily, floats in the toilet bowl, or has an unusually foul odor that is distinctly different from normal. This entire cluster relates back to the digestive enzyme function of the pancreas that I mentioned at the beginning. When a tumor disrupts the pancreas's ability to produce and release digestive enzymes properly, fat from food is not broken down and absorbed normally, and this undigested fat passes through the intestines and into the stool, producing the oily, floating, foul-smelling stool that is medically referred to as steatorrhea. This particular symptom cluster is frequently misattributed to irritable bowel syndrome, general food intolerance, or simply aging-related changes in digestion, all of which are far more statistically common explanations. What distinguishes this from ordinary digestive sensitivity is the specific combination of symptoms together, persistent rather than occasional, and ideally noticed alongside unexplained weight loss, since the malabsorption causing the abnormal stool is the same underlying mechanism contributing to weight loss through calories not being properly absorbed from food. The sixth symptom, the one I mentioned, gets attributed to so many other causes that the pancreatic connection is almost never made until later than it should be, is persistent fatigue that feels qualitatively different from ordinary tiredness, often described by patients as a deep, pervasive exhaustion that does not improve with rest or sleep, and that interferes with normal daily activities in a way that feels disproportionate to anything else going on. This fatigue relates to several of the mechanisms we have already discussed working together: the metabolic changes from cancer itself, the malabsorption of nutrients from impaired digestive enzyme function, and in some cases, mild anemia that can develop from chronic low-level changes in how the body is functioning overall. The reason this symptom is so consistently overlooked is that fatigue is perhaps the single most common, most non-specific complaint in all of medicine, particularly among older adults, where it gets attributed to dozens of far more common causes, including poor sleep, depression, thyroid changes, anemia from entirely unrelated causes, medication side effects, or simply the natural changes that come with aging. This is precisely why fatigue alone is never on its own a reason for alarm, but fatigue that is new, progressive, unexplained by any other identified cause, and especially fatigue that appears alongside even one or two of the other symptoms on this list, shifts from being an ordinary, expected complaint into something that genuinely deserves a more thorough evaluation rather than a default explanation. The seventh symptom is the sudden development of a blood clot, particularly in a leg, a condition called deep vein thrombosis, or less commonly, a blood clot that travels to the lungs, called a pulmonary embolism, occurring without any of the more typical triggers like recent surgery, prolonged immobility from travel, or a known clotting disorder. This connection exists because pancreatic tumors, more than most other cancer types, have a notable tendency to release substances into the bloodstream that increase the blood's tendency to clot, a phenomenon that has been recognized in medical literature for a very long time, sometimes even before the specific biological mechanisms were fully understood. This means that in some cases, a blood clot is actually the very first sign that leads to a cancer diagnosis, occurring before any of the more commonly expected symptoms like weight loss or abdominal pain have become noticeable. This particular symptom, when it occurs without an obvious explanation like recent surgery or a long flight, often does prompt thorough medical investigation on its own, simply because blood clots are taken seriously as a medical event regardless of suspected cause. But the specific connection to pancreatic health is not always immediately considered, particularly in someone who has no other symptoms yet and no family history that would prompt that specific concern. The eighth and final symptom is a sudden, unexplained aversion to specific foods, particularly fatty or fried foods, sometimes accompanied by a general loss of appetite that goes beyond simply eating somewhat less, extending instead to genuinely losing interest in food and eating that was previously enjoyed without any issue. This relates to several of the mechanisms already discussed, since the digestive difficulty with fat absorption can create an unconscious or even conscious aversion to foods that produce noticeable discomfort after eating them, while the broader metabolic changes associated with cancer can directly suppress appetite signals in the brain through complex hormonal pathways that researchers continue to study. This particular symptom is easy to dismiss because taste preferences and appetite genuinely do shift somewhat with age for entirely benign reasons, and people commonly develop new food sensitivities or preferences for various unrelated reasons throughout their lives. What makes this worth noting specifically is a relatively sudden onset of aversion to foods that were previously well tolerated and enjoyed, particularly when this shift accompanies other symptoms on this list, rather than appearing as an isolated, gradual change in personal taste that would be entirely expected and unremarkable on its own. I want to spend a moment on something important, which is understanding who faces a meaningfully higher baseline risk for this particular cancer, since this context matters for how seriously any combination of these symptoms should be taken in your specific situation. Risk increases with age, with the majority of cases occurring in people over 65. A family history of pancreatic cancer, particularly in a parent or sibling, meaningfully raises individual risk and is worth specifically discussing with a physician, since certain genetic testing and earlier screening conversations may be appropriate for people with this family history. Long-standing type 2 diabetes, smoking history, chronic pancreatitis, meaning long-term inflammation of the pancreas often related to either alcohol use or gallstone disease, and significant obesity are all established risk factors that increase the baseline likelihood of developing this cancer. None of these risk factors mean cancer is inevitable, and plenty of people with several risk factors never develop pancreatic cancer, while some people with none of these risk factors do. But if you have one or more of these risk factors and you notice any combination of the 8 symptoms we discussed today, that combination of elevated baseline risk plus a relevant symptom pattern is exactly the kind of situation that warrants a more prompt and thorough conversation with your physician rather than a wait-and-see approach. I also want to address something practical, which is what an appropriate medical evaluation actually looks like if you or your doctor decide that further investigation is warranted based on symptoms you are experiencing. This typically begins with blood tests, including specific markers that can sometimes be elevated in pancreatic cancer, though it is important to understand that these blood markers are not perfectly reliable on their own, since they can be normal even when cancer is present, and can occasionally be elevated for entirely unrelated, benign reasons, which is why they are used as one piece of information alongside imaging rather than as a definitive test by themselves. Imaging studies, particularly a CT scan of the abdomen with specific contrast protocols designed to visualize the pancreas clearly, or in some cases an MRI or a specialized ultrasound performed through an endoscope, are typically the next step, since these imaging techniques can directly visualize the pancreas and identify masses or other abnormalities that blood tests alone cannot detect. If imaging identifies a concerning finding, a biopsy, meaning removing a small tissue sample for direct examination under a microscope, is generally necessary to confirm a diagnosis definitively, since imaging alone, while very informative, cannot always distinguish with complete certainty between cancer and certain other conditions that can sometimes produce similar appearances on a scan. I want to walk through how a symptom pattern like this might realistically unfold, because seeing a concrete example often makes it easier to recognize something similar in your own life, rather than just hearing a list of possibilities in the abstract. Consider someone in their early 70s who, over the course of about 4 months, noticed their appetite was not quite what it used to be, attributing this initially to simply eating less as they got older, which is a genuinely common and usually harmless pattern. Around the same time, they began experiencing a dull ache in the upper abdomen after meals, particularly larger or fattier meals, which they attributed to mild indigestion and managed with over-the-counter antacids that provided some but not complete relief. They also noticed they had lost perhaps 8 or 9 pounds without trying, which they initially viewed almost as a positive development, since carrying somewhat less weight is generally framed as beneficial for health. Individually, each of these observations had a plausible, benign explanation, and many people would reasonably continue along this same path for months without seeking specific medical attention, since none of these symptoms alone felt alarming enough to prompt an urgent visit. It was only when a family member, seeing this person less frequently and therefore more able to notice the cumulative change rather than the gradual day-to-day shift, commented specifically on how much thinner they appeared and how tired they seemed compared to just a few months earlier, that a medical evaluation was actively pursued. This pattern, where the combination of subtle changes becomes more visible to someone who sees the person periodically rather than daily, is actually a recurring theme in how these symptoms come to medical attention, which is part of why I encourage people to take seriously not just their own self-assessment, but also specific observations from family members or close friends who notice a change that feels significant to them, even if it has felt gradual and unremarkable from the inside. I also want to spend a moment on lifestyle factors that genuinely do influence pancreatic cancer risk, since this is information people can actually act on, unlike family history or age, which obviously cannot be changed. Smoking is the single most significant modifiable risk factor associated with this cancer, with research consistently showing that current smokers face a meaningfully higher risk compared to people who have never smoked, and importantly, this elevated risk does decrease over time after quitting, though it generally takes a decade or more to approach the risk level of someone who never smoked at all. This is genuinely one of the more compelling reasons to quit smoking at any age, even later in life, since the body's risk profile does continue improving the longer someone remains smoke-free, rather than the risk simply being permanently fixed at whatever level smoking history had already established. Maintaining a healthy body weight also plays a meaningful role, since obesity is associated with increased risk through complex mechanisms involving chronic low-grade inflammation and altered insulin signaling throughout the body, the same broad category of mechanisms that connect obesity to numerous other health conditions as well. Limiting alcohol intake matters specifically because heavy chronic alcohol use is a leading cause of chronic pancreatitis, the long-term pancreatic inflammation I mentioned earlier as an independent risk factor for cancer development, meaning alcohol's connection to pancreatic cancer risk often works indirectly through this inflammatory pathway, rather than through a completely separate, direct mechanism. Diet itself has a less dramatically established connection compared to smoking specifically, but general patterns associated with lower cancer risk broadly, including diets rich in vegetables, fruits, and whole grains while limiting heavily processed meats, appear to offer some modest protective benefit for pancreatic health specifically, alongside their broader, well-established benefits for cardiovascular and metabolic health that we have discussed in other contexts. I also want to address diabetes management specifically as a risk reduction strategy, since we discussed earlier that diabetes itself can sometimes be an early signal of pancreatic cancer, but I want to be clear that this relationship also works in the opposite direction in an important way. Long-standing, poorly controlled diabetes that has been present for many years is itself considered a modest independent risk factor for eventually developing pancreatic cancer, separate from the scenario where new diabetes is actually an early sign of an already developing tumor. This means that working closely with your physician to maintain good blood sugar control if you have established diabetes serves a dual purpose: managing your immediate diabetes-related health risks like cardiovascular disease and kidney function that we have discussed in previous videos, while also potentially contributing to a modest reduction in long-term pancreatic cancer risk specifically. This is yet another reason why the comprehensive, attentive management of diabetes matters so much beyond simply keeping blood sugar numbers within a target range on a lab report, extending into this broader category of long-term health outcomes that are influenced by sustained metabolic health over years and decades. I also want to address a question that comes up often, which is whether routine screening for pancreatic cancer exists the way it does for some other cancers, like colonoscopies for colon cancer or mammograms for breast cancer, since people understandably wonder why this particular cancer is not caught earlier through similar routine testing. Currently, there is no standard, universal screening test recommended for the general population, primarily because the imaging and other tests available, while useful for investigating specific symptoms or concerns, are not considered practical or beneficial enough to apply broadly to everyone without symptoms, given the relatively lower overall incidence of this particular cancer compared to others that do have established population-wide screening programs. However, this changes meaningfully for people who fall into specific higher risk categories that I mentioned earlier, particularly those with a strong family history involving multiple close relatives, or specific genetic mutations that are sometimes identified through genetic testing when a strong family pattern exists. For these higher-risk individuals, specialized surveillance programs do exist at major medical centers, typically involving periodic imaging even in the complete absence of symptoms, specifically because their elevated baseline risk changes the calculation around whether proactive screening provides enough benefit to justify the testing involved. If you have a family history that includes 2 or more close relatives with pancreatic cancer or a known genetic syndrome associated with elevated pancreatic cancer risk, this is worth specifically raising with your physician, since a referral to a genetic counselor or a specialized pancreatic surveillance program may be appropriate even before any symptoms develop. I think it is also worth acknowledging directly that hearing a list like this, particularly involving a cancer with the reputation that pancreatic cancer carries, can understandably create some anxiety, and I do not want to minimize that this is a genuinely difficult topic to sit with. It is completely natural to feel some worry after reviewing a list of symptoms, especially when you notice that you have experienced 1 or 2 of them recently for entirely unrelated, benign reasons, which happens to nearly everyone given how common things like temporary indigestion or occasional fatigue are in daily life. I want to gently emphasize again that experiencing any single symptom on this list, especially in isolation, and especially when it resolves on its own, or has an obvious alternative explanation like a stomach virus or a particularly stressful week affecting your sleep and appetite, is overwhelmingly likely to reflect something far more common and far less serious than pancreatic cancer. The purpose of this information is not to create worry about every ordinary digestive hiccup or tired day, but specifically to help you recognize the difference between symptoms that fit a pattern worth a focused conversation with your doctor, and the much more common, much more benign explanations that account for the overwhelming majority of these same symptoms in daily life. I think it is worth closing with a clear, balanced perspective on everything we have discussed today, because I do not want anyone watching this video to walk away in a state of unnecessary anxiety about ordinary, common symptoms that almost certainly have nothing to do with pancreatic cancer in the vast majority of cases. Occasional indigestion, ordinary tiredness after a poor night of sleep, temporary back discomfort from physical activity, these are normal parts of life that everyone experiences and that rarely warrant specific concern about a serious underlying condition. What deserves genuine attention is the combination of symptoms persisting longer than would be expected. Multiple symptoms from this list appearing together rather than in isolation, and symptoms that represent a clear, noticeable change from your own personal baseline rather than simply ordinary, familiar discomfort you have experienced occasionally for years. If you recognize this kind of pattern in your own experience, the appropriate response is a clear, specific conversation with your physician, describing exactly what you have noticed, when it started, and how it has progressed, which gives your doctor the specific information needed to determine whether further evaluation is genuinely warranted in your particular situation. If this video helped you understand something more clearly, or if you have questions about any of these symptoms as they relate to your own health, leave a comment below because I read every single one, and I want this information to genuinely help you have a more informed and more productive conversation with your own doctor. Take care of yourself, and I will see you in the next one.